So I think what we basically see when she said isolates, we are looking at predominantly respiratory isolates. When we say gram negatives, we say Pseudomonas, we say Acinetobacter. We are looking at predominantly isolates from the respiratory tract, from the urinary tract. The blood cultures, fortunately or unfortunately, very rarely grow anything. That is the first thing. So probably that is the reason we are picking less and less MRSAs.
No, I mean, our blood culture 25% positivity rate, we still don't grow.
25% is a reasonably good rate, but I don't think it will interpolate all over the.
In fact, in ICU setting, it could be more.
So, staph is probably predominantly a bloodstream infection. Yeah. So, if you analyze all your blood cultures, you will find that the incidence of staph will be probably much higher. So, if you separate your isolates to blood cultures, tracheal cultures, urinary cultures, you may find the incidence of blood cultures which are staph may be a little higher.
I think we'll discuss this.
Sir, I beg to differ. Actually, this may be. I mean, this is not our experience as far as we are concerned. Our MRSA isolates from the blood are still much less compared to the gram negative. And if at all we are growing MRSA, it is from the wound swabs. And there it is, I mean, even if we grow from the burns patient or from other wound swabs, there are very few instances when we can prove it in the blood also. So in that case, it's very important for us to know it is a pathogen or a colonizer. Those things, in fact, I mean, houses here, many times when we are treating, it's a common thing. You report an ESBL from a diabetic foot, the patient goes on a carbapenem. I think these things are very, very important for everybody to know. We have to understand what is a colonizer, what is a pathogen, when to treat, when not to treat. And this opportunity when we have, I mean, everybody is talking about swine flu, and Mumbai is, all of us are so alert. We must take this opportunity to tell everybody that hand hygiene is something which we must practice. Without that, I don't think tomorrow, I mean, I don't know where we're going to be.
Absolutely, I agree. I think that's why I said focusing the use of a carbapenem, and it's the clinical assessment actually, the acute clinical assessment that focuses its use, because waiting for the microbiology, you haven't got that luxury, and it is a clinical assessment at the end of the day. And that's why, as you say, in the ITU, your highest pathogen in the blood is Klebsiellas, and as you can see from that data, almost 100% of those will be ESBL. So if you have all the signs of a true septicemia, then yes, that's the time to use it. But someone who's got some E. coli in a wound post-operatively, that's just a colonizer. I mean, you keep aware because it could develop into a septicemia, but it's much less likely to. I would agree totally. It's focus.
Yeah, I would say so. I think in our ICUs, the ICUs that we work, the blood cultures are usually all gram negative, so Klebsiella, pseudo. The tracheal secretions grow Acinetobacter. I had a patient who came in status epilepticus just 3 days back, ventilated overnight, culture sent in the morning because he thought she had aspirated. 2 days later, it's Acinetobacter. So I think it's also a lot to do with the property of the bug. It lives long in the ICU. It's there on the railings. It's everywhere on the curtains. It's on the ties. It's on the doctor's hands. So it's a lot to do with hand hygiene. MRSA, unfortunately or fortunately, not so common, especially in the blood cultures. The urine cultures usually grow E. coli, with a significant conic count. So I think for urine cultures, E. coli is a big bug.